We're going to give it over to 2 jurisdictions that have implemented the emergency petition and give them a chance to talk about their experience in their jurisdictions. So
Good morning. I'll start off. It's always interesting on Monday to get a phone call from your captain saying, hey, did you know about this meeting on Thursday with the sheriff? I was just like, no, I have some other training I'm going to. It's all right. A little while later, get the text message, check your email. Like, all right, here's the PowerPoint template that you're going to have. St. Mary's County, just so that everybody knows, we are in the state of Maryland. We're down in the southern part there. Sheriff Timothy Cameron has been the sheriff for a long time. We have a little bit over 100,000 permanent residents, about 20,000 people come in for the Naval Air Station that's down there. As far as resources with this, we have one hospital, MedStar St. Mary's Hospital, and we have only a couple of private mental health, addiction, substance abuse resources that are available or have been available to us in the county for a long time. Fortunate that that number is increasing as this problem continues. Not going to belabor the numbers. Everybody has the same numbers. We're affected just as much. And these are numbers as of the end of November of 17. Narcan, we implemented our Narcan for officers back in 2015. Probably started the discussion in 14, but it's increased. So you're looking at 18 people when we first started this discussion. And when we implemented the Narcan, we sat down with our chief health officer, Dr. Brewster, our ER medical director, Dr. Summers, myself, captain, the sheriff was involved, and we're like, okay, so what do we do after we gave the Narcan? And they kind of related it to the diabetic. Diabetic is unconscious, you give them D50, they come back to you, they're alert and oriented, you have them sign a release and they're on their way. The problem with that we saw is that with somebody that has overdosed, you also have that chance of relapse, and there's no connection to any type of resource to get that person additional help or anything like that. You can give the number to Walden or Pathways or what other resources that we had in the county, but you're going to give that number to them, and they're going to leave and sign that refusal, and what do we do from there? So we decided to implement, you draw the line in the sand with the Narcan administration. If they were experiencing an overdose to where they required the Narcan, we were going to implement the emergency petition. And this was done based off of the Maryland Code, the way that we interpret it, and our agency attorney interprets it. I know there's, and we talk about challenges as far as the interpretation of this. You're looking at a mental health illness, and you're looking at they did something to affect their safety. They overdosed to the point where they were unconscious or stopped breathing. They needed Narcan. We felt that met the criteria of something that affected their safety. And the mental disorder, we looked that up in the American Psychiatric Association, and everybody else that you talk to considers addiction as one of the mental health illness. So like emergency petitions seems to meet those criteria, so that's what we're going to do. The challenges, obviously, on the sheriff's office side of it, law enforcement, was that initial interpretation of the law. Not that it initially affected that many people. We were looking at, in 2015, having 18 people that required Narcan from the sheriff's office that more than likely would go to the hospital anyhow. And then those numbers have increased to 78 so far in 17. So we got some pushback from the hospital initially on this. They're like, why are you bringing them here? They want to refuse. It's like, well, and we went through the whole explanation that I said. So their issues was the impact on the emergency room, the beds, their staffing levels, their nurses, but also their behavioral health response from the hospital end of it. they would have somebody come up from their behavioral health, not necessarily an addiction specialist, or come down. If they weren't suicidal or anything like that, they gave them some information and they kick them out the door. It's kind of still the practice in what they do. They provide them the information and they're out there. So I don't know if that, from the hospital end of it, if it's a budget thing, there's not money in it, for them. I know they're supposed to be nonprofit, but there's that argument that comes up sometimes. From the health department, as we move forward with these overdose intervention teams, already 1 minute? Oh, goodness. All right. There's been some struggles with the health department getting data from the hospital for some reason, and useful data and interpreting that. But there has been progress. We've had a lot of partnerships that have developed out of this, the crisis intervention teams that we have with the sheriff's office, and behavioral health liaison that gets the information on all of these emergency petitions, and then the overdose intervention team. And the health department is looking to hire a addiction specialist and a peer recovery specialist to go out as a team, similar to the response of if we petition them. Right now, that's the standard practice. So that that team would go to the hospital to help that person through that crisis, and that might go into revisit the process of the emergency petitions.
So thank you, Lieutenant Russell. Why don't you stay up here? We also have a different law enforcement perspective from Cumberland City, so I'll leave Lieutenant Russell's information up there, but stay up here. We'll give a little minute for questions after both of you.
Good morning, everyone. What Lieutenant Russell said. I'm from Cumberland City Police Department. I'm the project director for the Safe Streets Project for Cumberland, Maryland, for the police there. I just want to give you a similar prospect as what he explained to you on emergency petitions. Each one of our overdose cases we do an emergency petition on. But let me just give you a few stats. 2016, we had 267 non-fatal and 47 deaths. And this year, we had 199 so far and 31 deaths. So we're down probably about 35%, not much, but we are down. And let me try to frame to you how we do a little bit of a comprehensive thing. Our chief in Cumberland City, along with our sheriff in Allegheny County, are very committed to working against this epidemic almost tirelessly, actually. Our sheriff has been doing a lot of town hall meetings. He's also been doing added another 1 hour to the DARE program in our county to talk and discuss with the kids about the drugs. He also took a utility trailer that he had and made it into a moving classroom. What he did with it is turn it into a small home, and he brings parents in and tries to explain to the parents what's happening in relationship to where the children could actually hide their drugs inside the house. It was kind of comical when he didn't tell anybody what he was doing. He kept searching for this commode, and we weren't sure what he was up to, but he kept telling everybody he needed this toilet, and finally he broke down and told us what it was for. But it has been very, very well accepted throughout the community. It's done very well. We get a lot of good participation in the town hall meetings too, so it's done very well. And as I mentioned to you, not only do we do the emergency petitions, we also do a program called DART, which is Drug Abatement Response Team. We put the team together, I guess, around the first part of the year. We have an officer teamed originally with a crisis counselor. We now team that person with a peer counseling specialist. We have found that the peer counseling specialist has been, more valuable to the program, has done much better with it. We've also bring in Pro and Probation with us. We have a partner with Pro and Probation, so they are actually working with us on that. And if any of those individuals who have overdosed is their client, they work with us and go out on this visit. We do them within 48 hours of the initial overdose, and it seems to be working very well. We've had 74 cases that we've done visits on since May, and 11 of those people are in treatment now. So about 17% of those individuals have sought treatment. We've also talked about doing the PARI as well, partnering with that particular organization. I think it's nationwide, about 50 law enforcement agencies in 31 states. But what we're trying to look at, we've talked to some of our people that our partnership with the hospital has been very good for us. And they've actually felt that some of our individuals who are recovering addicts, we could put them in the program, perhaps the Angel program. Those people who would relieve our officers once those individuals were referred to treatment or headed towards treatment. So we're looking at that to do that. We feel that because of a lot of our stats, a lot of our education, the things that we've been doing have truly helped, and it's been, as we all know here, I know I'm preaching to the choir, but it's been truly a community effort, and everybody's been involved, you know, our religious group, our academic people, everybody. And I can't say enough about the partnerships we have with our health department. They've been going to all our town meetings and been there the entire time working with us side by side. So it's been a very good positive outcomes. And I think the biggest thing is we all know in law enforcement we can't arrest our way out of this. So you know, what we're trying to do is direct these people into treatment and get them the treatment that they need very badly. Because those who are dope sick, we have to do something with. We can't just put them into steel, concrete, and glass. So that's some of the things we're looking at, just to give you an idea of some of the things. And we thank you for letting us share today some of the stuff that we do throughout our different counties. Any questions?
Yeah, let's open it up to a couple questions here. I know this is a topic a number of jurisdictions have looked into. Yes, sir, in the back, Carol.
For the St. Mary's model, one of the things that came to mind is a discussion amongst the OIT senior policy group in Carroll County, and that was the difficulties that we run into when patients were to be reversed by Narcan, analogously to the sugar example that you talked about. At that point in time, my understanding of Maryland law is like any other medical condition, including if someone's clutching their chest and they have an MI on their EKG, the right of self-determination by a patient is pretty sacrosanct in jurisprudence. And so the issue is a person who's reversed by Narcan who fully understands and can be informed, are they really analogous to the same danger to self or others like in a suicidal situation? And then the corollary to that is once they get to the ER, I had pointed out that almost every behavioral consult that you get, because they're EP, having seen this hundreds of times in my 25-year practice, the minute that substance abuse is the probable cause of the mental disorder that caused the EP, most psychiatric consultants, whether it's the nurse practitioner or in places lucky enough to have a consulting psychiatrist, will say they don't really need a psychiatric admission. They need detox, they need substance abuse care. So you're sort of at a brick wall in the emergency department because we don't tend to admit people who have primarily substance abuse problems without depression or suicidality. The minute they're not suicidal based on that, their disposition from the emergency department is difficult. So how do we reconcile that issue with jurisprudence and the fact that mental health professionals aren't the ones who usually feel like that's an appropriate mission in their church?
I won't make you summarize that question. I think underlying, have you had any challenges with your legal team in justifying the emergency
No.
petition?
The law enforcement officers are hesitant to EP someone simply because they know they could overdose again and have the same thing happen.
Right. So I know that there's several counties, so it's very kind of controversial for those reasons that you specified as far as the patient's rights, the human rights aspect of it, as far as once they get become conscious and alert and oriented. We took all that, and for the resources that we have available to us in St. Mary's, this is something that we developed in 2014, 2015. The resources haven't become readily available to us as quick as it seems that they have been in larger organizations. So we took it, we gave it to our county attorney, and said, from our agency attorney, and said, what is your opinion on this? And it was a decision made by the health officer and the ER medical director at the time, and the sheriff's office do that. I know that the Maryland State Police is the only other law enforcement agency in our county, and that they do not have the same practice that we do. So I know it's something that we definitely should reevaluate as these best practices come forward.
Well, and also to add to that, we also did the same thing in Cumberland City put it through our, our legal team. I didn't feel there's an issue there with it at all. We also felt that a lot of the officers and a lot of the EMS people are not practitioners in that particular field. We felt it'd be better that the person be evaluated at the hospital. So that's one of the reasons we do it. And we know that there are very few of us across the state that actually do participate in emergency petitions. Very few of us.
So Doc, very good observation. Glad you brought that up. This is something that we wanted to get them in here and talk about because we know that we have a problem statewide with people waking up from Narcan, either refusing service in the streets or refusing service in the hospital, and there are a lot of people dying as a result of that, going out re-overdosing. So we know that's a problem. It's an intriguing thought about using an emergency petition. Not sure it's a good fit, but it's being successfully done in 2 jurisdictions, so we're looking at it closely. We also know that if we tried to do this in the urban or suburban setting, it would break our emergency departments. Right. I mean, you couldn't surge up to deal with it. So what I will say is that we have this as an agenda item at the state level. Yeah, I'll pitch it to you. We have this on our agenda at the state level and looking very closely at it. And as we talk about how we could engage the legislature, we share this as a challenge. Not sure what we're going to end up doing with it, but we recognize it at that level, it's a challenge. So we have the health officer from Charles County back here that wanted to say something, I think, right?
Yeah, I just have a question for both of you all. Of the people who get EP and go to the emergency room, how many of them are just evaluated and then sit away from the hospital? Because the reason I'm asking, I'm thinking of resources, because to go into an emergency room, it's about $1,200 no matter what. That's the average. And then my question is, if many of them, like let's say 60, 70% of them are just leaving and not getting anything more done.
We're seeing many of our,
Kind of piggybacking on.
I understand exactly what, yes, I understand that. We're seeing a good many of ours that actually have been admitted. And one of the things, I guess one of the mindsets that we have on the law enforcement is also to present these people to a treatment, to get them into some type of clinical setting that hopefully they'll reach out for that treatment further as well. So we're seeing probably, I guess, 40-some%, somewhere in there, that the hospital is actually keeping. So you've got about maybe 60 or 58 that's not.
So does the hospital have a warm handoff that helps make that happen?
Yes.
So that is an excellent question.
And
It will help us lead. So our next presenter is coming from an emergency department who can talk about emergency department
most of that's
protocols.
through our health department. Our treatment facilities there. And we, through our DART program, we've also offered them either go to the hospital or through the health department. And the health department, of course, takes them in and works on developing their treatment modality and so forth.